I would like to now invite Dr. Strike to the stage. Karen is currently working as an advanced practice physiotherapist in the bleeding disorders program at McMaster University Medical Center in Ontario, Canada. She completed her degree in kinesiology, her master's in physiotherapy, and her Ph.D. in rehabilitation science at McMaster University. Karen is an assistant clinical professor adjunct at McMaster University and a part-time faculty member at Mohawk College. Dr. Strike's principal research areas include best practices for the assessment and management of the musculoskeletal implication of a bleeding disorder, point-of-care ultrasonography, patient engagement, and physiotherapy scope of practice. Dr. Strike is a faculty and a founding member of the McMaster University Mohawk College POCUS training program. She will now be speaking to us about joint health with non-factor therapies. Are we really doing as well as we think we are? I will let you listen and be the judge. Welcome, Karen.
Thank you. And thank you. Can you hear me okay? Perfect. Those for the vertically challenged, I just have to set myself up here. So thank you to the CHS and for the organizing committee for inviting me to speak today. As you heard, I'm Karen Strike, and it's a pleasure to come and speak to you about joint health and non-factor therapies. Is it just the green one at the top? These are my disclosures. When looking at prevention of bleeds in hemophilia A, factor levels of up to 50% may be needed to achieve a near zero joint bleed rate. This slide is a summary of retrospective and post-hoc analysis evaluating the association between factor levels and bleeds. The top two studies looked at patients with severe hemophilia A, and the bottom two studies looked at patients with mild and moderate hemophilia A. Overall, all four studies showed a correlation between higher factor levels and zero bleeds. More specifically, factor activity of between 15 to 50% was associated with near zero joint bleed rate. Target factor levels were developed using structured expert opinions and a modified Delphi method. As shown in the figure, factor levels of 1 to 3% have been recommended for patients engaging in a sedentary activity, 5 to 15% in high-risk activities, for example, soccer, basketball, and anywhere from 50 to 80% for those engaging in very high-impact activities, for example, ice hockey, American football. Similar escalating factor levels are suggested for clinical scenarios. 1 to 3% is recommended for patients who have moderate hemophilia or those with a mild or bleeding phenotype. Factor from 15 to 30% for those with target joints or for patients who've had breakthrough bleeds. And levels between 30 to 50% for those who have had major surgery. Again, the eyes, I can't really tell if I need the glasses or not. For patients who had major surgery after an initial period of high-dose treatment. And in particularly, I want to highlight the 30 to 50% for the resolution of chronic synovitis. Finding the optimal target of achieving minimal bleeding is crucial. As Dr. Matino already discussed, to reduce treatment burden on patients with severe hemophilia, non-replacement therapies are becoming available, offering less frequent subcutaneous infusions for prophylaxis or gene therapy. Non-factor therapies have the potential to convert a severe bleeding phenotype into a non-severe bleeding phenotype with a more continuous pharmacodynamic profile and infrequent on-demand requirement of factor VIII. As Dr. Matino also stated, the goal of prophylaxis is to prevent all spontaneous bleeds. Several clinical studies have reported a majority of patients now who have access to the novel therapies have achieved zero joint bleeds. However, these studies typically record patient-reported bleeds or only bleeds that required factor treatment. Even in joints with no history of reported bleeds, diagnostic imaging has revealed the evidence of bleeds in the form of osteochondral damage, synovial hypertrophy, and/or hemosiderin, and subclinical bleeding is being suggested to be the cause. We all are very familiar with these two sentinel studies in hemophilia, the joint outcome study by Marilyn Manko-Johnson and our own Canadian hemophilia prophylaxis study. In both of these studies, MRI detected joint changes in boys with hemophilia despite no reported bleeds. And so we know that there is some chronic, potentially microhemorrhaging that could happen in the joints and subchondral bone that can result in deterioration of the joint without any clinical evidence of hemarthrosis. We also have some more recent data that has shown that joints that show no clinical bleeds and normal physical function may exhibit early signs of joint damage. In a study from Spain, in an analysis of 203 joints from 66 participants with hemophilia A and B of any severity, they were assessed by ultrasound. And 40% of the joints that had no swelling, no pain, and no history of hemarthrosis presented with synovial hypertrophy. From a group in Italy, our Italian colleagues, they looked at 40 clinically asymptomatic joints with no history of bleeds in patients with severe hemophilia A, and they matched those with 40 joints in patients with healthy matched controls. And in this study, they found 35% of the hemophilia A joints presented with mild synovial hypertrophy, and 20% had moderate synovial hypertrophy. When compared to the age-matched healthy controls, they had no findings of synovial hypertrophy in any of their joints. So we know in this study too, MRI was able to detect hemosiderin. This is from our Dutch colleagues, and they looked at both severe and non-severe hemophilia, given the goal that many of the non-factor products are to convert patients from a severe bleeding phenotype into a more mild bleeding phenotype. So they first started with the study on the left in patients with severe hemophilia, and they had 43 patients and studied them with MRI. 16% of the joints that were shown on MRI presented with hemosiderin with or without synovitis, despite having no reported bleeds. Then they looked at patients with non-severe hemophilia who had a median factor VIII activity of 10%, and they found very similar 14% of those patients with non-severe hemophilia had findings of hemosiderin on MRI despite no reported bleeds. And so they then moved on, our Netherlands colleagues continued their work, and they decided to look at prospectively, what can MRI tell us about what's at risk for the joints? And they started this study by investigating patients with absent or limited arthropathy, and they underwent an initial MRI assessment for subclinical bleeding of the knees and ankles. And then they were followed for a median of 5 years. Synovial hypertrophy was detected at baseline in 16% of the joints, and it was a strong independent predictor for 5-year joint bleeding risk. As you can see in the diagram, the blue line at the top are the joints that presented with synovial hypertrophy at baseline, and their 5-year joint bleeding risk was 80%, compared to those at 27% that had no synovial hypertrophy on MRI at baseline. In terms of arthropathy, synovial hypertrophy at baseline is that patients who had synovial hypertrophy were 24.7 times more likely to have progression of arthropathy by 5 years. And then we'll just move on to some of the non-factor products and talking a little bit about emicizumab. So as Dr. Matino talked about, emicizumab is approved for prophylaxis in patients with hemophilia A. And despite its efficacy in reducing bleeding, some patients still experience hemarthrosis. But no tool is currently available to identify those who are at higher risk of bleeding. And so this study, their aim was to evaluate whether global coagulation assays and emicizumab concentration and or arthropathy scores, which included the HEAD-US and the CHS, could distinguish from patients who are at higher risk of spontaneous joint bleeding while on emicizumab prophylaxis. They had 40 patients with severe hemophilia A, both with and without inhibitors, and 25% of their cohort developed spontaneous joint bleeding. There was none of the laboratory parameters were able to distinguish those patients from who would bleed and who would not bleed. And the presence of synovitis and a higher HEAD-US score was associated with spontaneous joint bleeding over their 18-month follow-up period. We also know that there's some discrepancies in terms of our clinical exam. And so this slide just highlights that despite a strong correlation between the HJHS scores and the 6 index joints of hemophilia, our clinical exam can miss signs of synovial hypertrophy. And in this study from the Netherlands, they found that 18.4% of joints had synovial hypertrophy on ultrasound despite no swelling. And studies have also shown us how ultrasound can impact patient management. In this study, it was a study from Israel, and they led children and adults that had hemophilia and von Willebrand's disease. Some were on factor prophylaxis, some were treated with emicizumab. And when they presented to clinic with acute musculoskeletal episodes, they were assessed clinically and with ultrasound. For all the episodes, the initial diagnosis and treatment was determined by the clinical team and by the clinical assessment, and a treatment plan was drawn. Then a physiotherapist did a point-of-care ultrasound assessment. Ultrasound changed the diagnosis in 36% and the treatment plan in 39% of the 77 musculoskeletal acute episodes that were presented in 67 patients. They found that they had missed 9 joint bleeds and 2 muscle bleeds with the clinical assessment alone. So this study supports that the use of ultrasound in addition to our clinical assessment in acute musculoskeletal episodes is important in bleeding disorders. We do have some emerging real-world data on what's happening with patients with hemophilia A who are treated with emicizumab. This study was a prospective study, and they followed patients for just over 18 months and looked at bleeding episodes. 51% of the patients, and the patients were aged 1 year to just shy of 75 years old. 51% of the patients experienced at least 1 spontaneous bleed, and 61% of the patients had a traumatic bleed. Most trauma bleeds were related to hemarthrosis, as you can see on the diagram on the left. Most were joint bleeds, and 80% of the spontaneous bleeds were hemarthrosis. The only factor that was found to be a risk factor in this patient cohort was increasing age. And so with each year of age that increased, the odds of a spontaneous joint bleed increased by 2.9%. And so this study helps summarize that although emicizumab has significantly reduced his bleeding in many patients with hemophilia A, the risk of both spontaneous and traumatic bleeding persists, particularly among older adults. And we need to maintain our vigilance in terms of our musculoskeletal assessment for monitoring for those signs of some clinical bleeding that can perpetuate into a more overt bleeding, and try and work with the tools that we have to individualize our treatment plans. We also have some data on emicizumab and muscle bleeds, and this is a real-world retrospective study that was conducted at 4 hemophilia treatment centers in the United States with about 314 patients with hemophilia A. They included hemophilia A patients on emicizumab who had 1 or more severe muscle bleed. And the severe muscle bleed was characterized as needing more than 1 day's worth of factor treatment. And in this particular cohort, they had 14 bleeds in patients without inhibitors and 5 in patients with inhibitors across 15 male participants. In terms of the bleeding, the average number of treatment ranged from 12 to 15 days of treatment following bleed, and 3 of the patients required hospitalization. The quad, or the thigh muscle, was the most common site of bleeding, followed by the iliopsoas and then the calf. Most bleeds were caused by trauma, and most were related to physical activities, which we do know that our patients who are electing to go on emicizumab is they are doing and playing more different sports now with the novel therapies that we have. All patients chose to stay on Hemlibra after the bleeding episode, although 2 did change their regimen and went from every 2 weeks to once a week dosing. And so this data really highlights for us that we need to be quick in recognizing bleeds. This population of emicizumab patients is also very unique because of the subcutaneous administration of emicizumab in terms of their ability to maintain their IV access. Is for some of these muscle bleeds, did they become severe because patients waited? Is that they may have had a trauma, but then they waited to see what would happen, and then they developed large muscle bleeds that required prolonged factor administration. And then I'm just going to transition just a little bit to gene therapy, but I won't talk a little bit too much about it. But we all know that hemophilia is a hematological condition that has orthopedic manifestations. Gene therapy is designed to correct the coagulation system. And we don't have a lot of data on the musculoskeletal outcomes for gene therapy. Things are just starting to come out. But this was a case study of a 26-year-old male with severe hemophilia B who underwent gene therapy transfer. And although he had no bleeding events and required no factor IX replacement infusions throughout his time after gene therapy, his joint arthropathy progressed with significant changes in his HJHS score, and he ended up having a total knee replacement on day 479 after vector transfer. And I just bring up this case just to maintain our ongoing vigilance around the musculoskeletal implications of the bleeding disorder. Although our ABR and our factor levels may be approaching the normal range, we still need to maintain our vigilance in terms of monitoring for the musculoskeletal implications of the bleeding disorder. So as a physio, I have to say, well, what does that mean for clinical practice? What should we be thinking of doing? With the advent of non-factor therapies, the clinical landscape has changed dramatically. And so we know that this new paradigm will introduce challenges. So that makes imaging more than ever an important tool that we should utilize. As I've shown, subclinical bleeding is hard to detect clinically. And we know that our clinical assessment alone is inadequate. We also have more and more emerging data that synovitis is one of the main predictors for future bleed risk and progression of arthropathy. So we all need to think about ourselves, how is the best way for us to detect synovitis? How are we with our clinical skills, and how are we integrating either diagnostic ultrasound where someone goes down to a diagnostic imaging department, MRI, or point-of-care ultrasound into our outcome measurements. And it's really important that we do this to monitor our treatment efficacy and to individualize our treatments. In Canada, we're in a really unique position that we have access to lots of these novel therapies. And so I would empower patients and clinicians to participate in collecting some of the real-world data, and so that we can start to track and collect some of the ultrasound data and contribute to some of the evidence that we're seeing on some of these novel products. I also am going to talk a little bit about this term subclinical bleeding, because subclinical bleeding kind of implies that your patient doesn't experience any symptoms at all. And I would argue that maybe subclinical is not necessarily the correct term, because it might be that your patient is not experiencing no symptoms, is that the symptoms they're experiencing might be different. And they might not be registering the same symptoms that they had in the past when they had overt bleeding episodes. So I'm going to encourage people to try to avoid overly binary questions of, have you had any bleeds since your last review? We know that ABRs are substantially low, so 99 times out of 100, you're probably going to get the answer, no, I haven't bled. However, I would challenge you to answer questions more nuanced, for example, like, do you ever experience joint discomfort, swelling, or stiffness that didn't feel the same as bleeds that you may have had in the past, but affected your movement or your ability, or resulted in missed time from work? Or you used adjunctive therapies like rest, ice, elevation in order to manage your symptoms? Have you noticed any changes in how you walk, stand, or exercise, or how you use your limbs for daily tasks? For example, did you used to always be able to wash your hair with both hands? Now you're just using one hand. Is that if we only ask the question of how we've had any bleeds, we may be missing some things. And lastly, and this kind of goes to our lunchtime symposium in terms of the psychological impact of some of the therapies, in terms of, have you adjusted or limited your activities because you're uncertain? You don't know what a bleed is a bleed anymore, and you might be fearful of bleeding, and so you may have changed the activities. So I think we have to try and start to change how we're questioning, because ABRs are so low, so why are we still asking, have you bled? And then lastly, my last slide, with the novel therapies, our traditional measures are no longer maybe fully capturing the patient's health. And so for performance-based functional measures, assessments such as the 6-minute walk test and the other measures that are on the slide that have been shown in the literature to be meaningful to patients with hemophilia may provide essential real-world data on mobility, endurance, and overall functional health that are meaningful to our patients. So stay tuned on this, because there's more literature that'll be coming in the coming months in terms of the psychometric properties of these tools for our patients with bleeding disorders. Thank you very much.
Thank you, Karen. Does anybody have any questions? Sorry, Adrian. Stealing your thunder. Any questions? We got a couple. Oh, yep, Tom's making his way up.
Thank you, Dr. Strike. That was a really wonderful talk. I'm thinking about my pediatric population who, by virtue of being young and rambunctious, have lots of kind of small injuries as well. Like if we're thinking that this is something that could change management potentially, if you have like this build-up of synovitis, like what do you think we can do clinically to better differentiate what is just a regular, I've fallen and bumped myself versus I am having kind of this active synovitis, just because you're not going to get that DI piece readily and everywhere, right?
Yeah. And I think that's the thing is that we know that ultrasound is a really helpful tool. And so I think we should be going to our centers. And if we don't have the ability for point of care ultrasound at the bedside in our centers, then we should be getting a relationship with our diagnostic imaging departments to see. I know that there is a trend for a number of centers that have more readily access to MRI, is that they're doing routine MRI scans of patients to be able to better detect when they don't have access to ultrasound in clinic. I'm hopeful that some of the functional performance-based measures may also give us a little bit of a discriminating factor, is because we know kids are self-limiting, is that when something hurts, they don't do it. And so if there is one of the tools that we had on the screen, if there is, a single leg hop for distance, that we're seeing a change over time, we know that it's a measure of joint health, strength, and endurance, is that maybe we'll see subtle changes in that ability that is clinically relevant, that we might be able to differentiate that something's just a little bit different, and then would cue us to say, okay, well, what might that be? You haven't reported any bleeds, you're still very active with soccer, but last time you were here, there's a significant difference in terms of your endurance and power on that ankle. What's changed? And so then I would encourage you to, reach out to your diagnostic imaging colleagues or your colleagues in point of care to see if you can look at changes. And we hope to be having a pediatric atlas for ultrasound coming out, because children in ultrasound are very challenging. They have very hypermobile joints. They have open growth plates with large, growing cartilage. And so I think that we're going to have a little bit more information on the pediatric patient in ultrasound soon.
Amazing, thank you. So more POCUS for more physios is what I'm hearing.
More POCUS, more physio, exactly.
Any other questions? I have a question for you, Karen.
Yes.
So this discussion about how we are converting patients to a more mild phenotype and potentially bleeds are not presenting the same way as they used to. Can you talk about maybe how you have seen a difference in how bleeds are presenting, or how patients are presenting to the clinic that ends up being a bleed?
I think the biggest thing that I've seen is when they come in and I ask my nuanced questions, is they'll say, oh, yeah, no, I haven't had a bleed. And then I'll say, okay, well, tell me what you've been up to. And then they'll say, oh, there was a day where my ankle was really sore, but it didn't swell. I didn't lose my range of motion, but I rested. And then I'll get them to do some functional tasks, usually squat, usually doing some other functional tasks. And then I'll notice that they're favoring it a little bit. And then usually the HJHS score doesn't change. And then I will present with doing some ultrasound. So I think patients is that they're looking for these large overt signs of bleeding that we've trained them to look for, is that we've trained them to look for swelling, loss of range of motion, and they're not presenting that way. They're presenting with more subtle changes in function, and even just this, they're like, something just doesn't feel right. It was just a bit funny. I thought it might bleed. I thought it might be becoming a bleed, but then I rested, and then I think it was fine. And so I think that that's where even like our patients are teaching us about these novel therapies, because they themselves are not experiencing the overt symptoms that we used to associate with a joint bleed. Yeah.
Yeah.
Karen, thanks for your presentation. I have a question about, so we now have a range of treatments that allow us to have persistent hemostatically useful levels, 15, 20%. Those have been given predominantly to adults who've had previous issues. So do you think when we're able to use these new amazing agents from early childhood that we're going to see the synovitis and the microbleeds, or do you think we can actually abolish musculoskeletal problems entirely?
Based on only the data we know about emicizumab in the one study, did follow children from age 1, and they did still see the development of synovitis in some of those young patients with emicizumab. I think that the tricky thing is that our patients that are on some of the steady state products is that they are very physically active. And so we're learning that we still might need the protection of the peak in order to engage in the higher level physical activity, whereas the potential for more joint trauma and the potential for having a small little seeping bleed that the emicizumab might keep it at a steady simmer and not necessarily present as an overt bleed. And so I think that definitely the proportion of patients that could be bleed-free if we start at an early age is definitely more without the development of arthropathy, but I think it needs to be individualized, that there might be some patients who have a more severe bleeding phenotype or engage in much more high-risk activities where they may need higher levels to participate in those tasks. Yeah. Lots of questions.
Last one, I promise.
Yeah.
Maybe a quick comment, Karen. You showed us again that our clinical assessment is actually not enough.
Yeah.
Not in just 2%, 3% of patients, in a significant amount of our patients, 20, 30% maybe. So, and it seems that in this current environment, it seems to me that the role of imaging is actually becoming increasingly important.
Yeah.
What are your thoughts on that, and what do you think about it? I mean, is it time that we really shift the way that we do our clinical assessment now? Because it looks like maybe I don't listen to you when you talk, but I do.
Yeah.
And it seems to me that every time that you do, you tell us that our current evaluation is insufficient to detect those changes, and those changes will have consequences.
Yeah, and I would concur, is that I feel that imaging needs to play a larger role. I'm not saying that we need to throw the HJHS the window. I would just say that maybe potentially we need to do a decreased frequency of HJHS in terms of, we know joint health changes over a long period of time. And so if we're doing HJHSs every 6 months on a pediatric patient, potentially, is that the best use of our time? Or should we be doing diagnostic imaging, point-of-care ultrasound when our time is limited in clinic, and potentially functional performance-based measures, because those are what are meaningful to patients. And of the ones that I put up on the screen, they're all short, clinically feasible, and there was a very good abstract that was just presented at WFH that showed many of those performance-based functional measures could be administered by telehealth visit, and that the patient could collect that data on their own. So it requires no special particular physio skill to do those performance-based functional measures. So I agree with you, David, even though I can't see you, that yes, is that potentially should we be moving away from relying so heavily on the HJHS when time is limited? If ideally we had enough time that we could capture all of the data, that would be great. But if there is limited time, then I would say that we need to start thinking about other tools that might give us more meaningful information. Thank you very much.